Hello, my name is Dr. Sundar. I'm one of the interventional pain physicians with OrthoVirginia. Today, we're just going to have a brief discussion about compression fractures, overview of them, what they are, how to diagnose them, and how we could possibly treat them. And we'll get started. So first and foremost, what is a vertebral compression fracture? So like it says, it is a fracture, so it's a break of the bone, specifically of a part of the vertebra of the spine. So that's like the big disc-like portion of the spine that sits in the front. And what happens, it compresses. So it could collapse or crush. And mostly we see it in the low back or the lumbar spine, but it can be seen in the thoracic spine as well, which is the mid-back region, right above the lumbar spine. So I just want to show a quick diagram of what a compression fracture is. So on the left side, we see what's labeled as healthy spine, where all the bones are good, equal height. We see them as nice, almost rectangular structures. But in the one on the right-hand side, where we see wedge fracture or the weakened spine, we see that the front of the bone is squished in relation to the back of the bone. And that's that compression, hence the term compression fracture. And there's another more of a live image. This is an MRI image that's highlighting the different areas where there's a fracture. This image is nice because it shows in red exactly where those fractures are. So you could see the areas that are not in red, nice square rectangular structures, all well-defined borders. But in the areas where you see the red, you could see that either the middle of the bone is pretty squished or the front of the bone is compressed. So there's clearly two fractures on this image, specifically the L4 and the L1. So again, these are both in the low back. And previously we saw an MRI image. This is an X-ray image of what a fracture can look like. So same thing, same concept, but repetition is key, where we see the red arrow pointing to a sideways view and a frontwards view of the spine, where we see the front of the bone is compressed in relation to the back of the bone. And we see the shape of this bone is very different compared to everything else, which looks more even, defined, square or rectangular-like. So what can cause a compression fracture? At least in my patient population, the most common cause that we see is due to low bone density. And low bone density can be defined as osteopenia or osteoporosis. We'll get into more of that in just a minute. Unfortunately, sometimes cancer, either cancer of the spine or because cancer has spread to the spine, can also weaken the bone and can cause this fracture to occur. And sometimes even trauma. Trauma doesn't have to necessarily be a huge fall. It can be. Where I work, we have seen people with work-related injuries or falling off of horses after riding with trauma. But even mild trauma like illness, so a lot of coughing, heaving, bending, twisting, that too is a form of trauma that unfortunately can also cause a fracture to occur. So the bone density, so I said I'll get into it. This is a very important thing to understand because lower bone density is a risk factor for getting a compression fracture. And it's normal for the density to decrease over time, but the patient population more at risk of decreased bone density are women after a certain age, especially after menopause, because after all the hormonal changes occur, the bone unfortunately becomes a bit weaker. So you see the matrix of the bone gets weaker over time, and then that's why sometimes even this heavy bending, lifting, twisting can cause a fracture to occur. And one of the things we do to check the bone density is called a DEXA scan. So if I see a patient with a fracture that hasn't had this done, I always order this. So we could see what the numbers look like and set that patient up with the appropriate care to be treated if necessary. And there's two scores. There's a T score and a Z score. So as it says on the screen, a T score will compare your bone density of an average young healthy adult, and the Z score compares it to kind of you're within that age group. And it's all based on the number. So if it's -1 and above, that's normal density. If it's between -1 to 2.5, that's a weaker bone or osteopenia or low bone density. And when it's significantly weaker, that's when it's -2.5 or below. So that's why if it is even if it's under 1, not quite osteoporosis, you're still at risk of having a compression fracture. And like I said, in terms of the bone density, fractures do often appear those with low bone density or osteoporosis. if you kind of think of the type of bone we're talking about in the vertebra as like a thick mesh of bone or spider web like matrix of bone, that can get weaker over time. So the strings of the web aren't as strong, the tensile strength is decreased, and if they crack, that causes that compression. And when you do these scans, they kind of look at multiple areas, but areas that are most susceptible to fracture are the femoral neck, which is actually part of the hip. It's the region underneath the ball portion of the hip. Wrist fractures can be common, and the vertebra or the spine, that can also occur as well. So risk factors, again, age. Older we are, unfortunately, the higher the risk. Female, postmenopausal, osteopenia, osteoporosis, cancer, trauma, and other things that also can put you at risk are smoking, low body weight, and then unfortunately history of compression fracture as well. So if someone has an old fracture, whether it was treated or not treated, that can potentially increase the risk of another fracture down the line. So how does a fracture present, right? So most of the time it's acute sudden onset of back pain, whether that's in the mid back or the low back. Sometimes patients get abdominal pain based on where the fracture is located, but typically any sort of movement can worsen the pain. So that's bending over, bending backwards, twisting. And sometimes what helps the patient decrease that pain is kind of bending forward to offload some of that pressure. And usually if sitting down or laying flat takes off the weight off the spine, so that oftentimes decreases the pain as well. So how do we work this out? So you come into the office saying, well, I fell, or I have this really acute onset back pain. What do we do? First and foremost, an x-ray. What do the bones look like on the different films that we see compared to what are the x-rays that we showed before? And we take a look at it. If we're suspicious that something might be going on, we want to work that up further with more advanced imaging, such as with the MRI, if possible. Not every patient can get an MRI, but sometimes we can get a CT scan as well. And the reason behind getting advanced imaging is, especially on the MRI, we can see how much the bone is compressed. Are there nerves involved? Is the fracture so bad that it's pushing back on some of the nerves? And we could even see how new the fracture is on an MRI. Has this fracture been around for a long time, or is this relatively new fracture? And then bone density scan. Again, very, very important in my opinion, part of the workup, because if I have had patients that haven't been worked up at all, we get the bone density scan that shows low bone density. So we talk to their rheumatologist or primary care physician so that they can be placed on the appropriate treatment plan to hopefully strengthen the bone and decrease that risk of future fractures. So how will we treat it, right? You come in, we've worked it up, we've decided, yes, this is definitely an acute fracture. So what can we do about it? Sometimes doing nothing can be best. If you're not having any pain, I often say we just treat this very conservatively and we'll go from there. So what are conservative measures in which you can treat it? Bracing, so LSO or TLSO, I'll get into what that means in just a minute. Decreasing the amount of activity that you're normally doing. So unfortunately, to let the bone heal and let's let it rest, sometimes it's best just to take a few weeks of decreased activity. Medications, so pain medication specifically. The easiest thing we could do are over-the-counter medications such as acetaminophen, or non-prescription anti-inflammatories such as ibuprofen or Advil if there's no contraindication to other medications. But this is a fracture. It hurts. So sometimes we need more stronger pain medications such as opioids and narcotics for a short period of time while the fracture is healing. And then once pain is decreased, if we didn't do other interventions for it and the pain is improving, I typically will refer patients to physical therapy. Why physical therapy? Because if you haven't been active now for about 10 to 12 weeks, what can happen is called deconditioning, where the back muscles, the core muscles can weaken a little bit. So we want to do PT just to kind of strengthen you back up and get back to where you were before this fracture occurred. So this is a type of brace. So this is an LSO, or a lumbosacral orthosis. So this one is for a fracture of just the low back itself. It's pretty, it just wraps around the low back, around the hips. It's pretty self-explanatory. But then the next one, it's a little bit more involved. This is a thoracolumbar orthosis, a TLSO. This would be more for a compression fracture of that mid-back region. So we could see here, this is clearly more involved. There's a big back plate and a bigger, more supportive girdle around the waist to support that mid-back region as well. Depending on the fracture, obviously we'll make that decision of which brace is most important. But the purpose of the fracture is to provide that stability and balance so that even if you are a little bit more active, there's decreased pain and keeps the spine in a good neutral position as best as possible to allow that healing to occur. So let's say, we've done the bracing, you've tried some medications, the fracture is still pretty acute, but you're still having pain despite these conservative treatments. We could go in and physically try to fix this fracture. And the techniques are called a kyphoplasty, which is what I do, or a vertebroplasty. The approach is similar. The goal is to reduce the pain coming from the fracture, provide balance and stability to the spine so that you can get back to doing the things that you enjoy to do. And no matter what, although the approaches are different, the goal is we want to fill that fracture with cement. And it's a human-grade cement. Cement has been used in orthopedic procedures for some time, like in knee replacements or hip replacements. This is just another application for the cement. Why would we do it? So like I said, the rationale of putting cement in the fracture: stabilize that fracture so it doesn't collapse any further, stabilize that vertebra, reduce your pain, and just hopefully get that patient back to functioning as soon as possible. So I'll show you some pictures, but just to describe it in words, a vertebroplasty is where you gain access into that fracture and you fill cement within all the fracture lines. The difference is in what's called a kyphoplasty, we inflate a small balloon to create a cavity within that fracture, deflate it, take it out, and then within that cavity, we try to fill the cement. No hardware is left in place, only the cement, so no bone like screws or rods or anything like that for this particular type of procedure. So this procedure outlines what's called a vertebroplasty. So on the left hand, we see a thin hollow tube entering from the back going towards the front of the bone. And on the right side of the screen, that red just is showing the cement in illustration form, filling in that fracture line. So the difference is in the kyphoplasty, similar concept, just it's a little flipped. We come in from the back, a hollow tube is gently inserted into that fracture. You inflate a balloon, you deflate the balloon, and then you see the white, in this case, the cement being filled in that place. And then you take everything out, and that final image you see on the right is on the cement, no tools, no hardware left in place. And this is more of just of a technical slide. I just wanted to show if someone says, well, how do you get into it? So what's labeled as A, the bottom is the back of the patient, the back of the spine, and the top of the screen is the front of the spine. So a thin hollow tube is slowly tapped into the bone. And slide B shows a sideways view where we're coming in from the back towards the front as much as we can towards that fracture. And what's labeled as C is me looking at that spine from back to front. We want to try to get towards the middle of the spine as best as possible to optimize the spread of the cement. And so we previously saw images of what fractures look like on an x-ray. This is what it typically looks like after the cement and everything is put in place. So the image to the right shows that more of that frontwards view of that cement beautifully crossing that spine from left to right. And then on the left, the top picture shows the before. You could see towards the top of that screen how it looks like everything has been wedged down. And when you look at the bottom, this patient has had very good cement placement to not only cover the fracture line, but very good spread of the cement itself. So just to outline a kyphoplasty, it's an outpatient procedure. Different physicians, different settings will do it differently, but we're fortunate enough that we're able to just do it right here in our office at an outpatient. So we just use local anesthetic or some mild sedative medication. A lidocaine or numbing agent goes a long way in keeping it comfortable. The incisions are very small, maybe half an inch to an inch at most. And it's usually just one incision. If I could get away with just going in through one segment, we do. Worst case, there's 2 incisions, but again, they're relatively small. 60 to 90 minutes, pretty conservative for just a single level. You could do them in about 30 to 40 minutes, but for conservative, I always say 60 to 90 minutes. And, because we're doing it in the office with just local anesthetic, there's no fasting involved. You don't have to worry about like general anesthesia or anything like that and the possible side effects with that. And as an anesthesiologist, I'm also saying this is a better approach to take. And typically we do one level, but you can do up to 2 levels at a time. So this is not a procedure that requires hospitalizations or prolonged inpatient stays or prolonged rehab stays. We're very fortunate that a lot of the patients that get this done, aside from a little bit of soreness from the procedure, have significant pain reduction shortly afterwards. So the procedure itself, the mechanics of it, you are laying flat, but then afterwards, cement hardens pretty quickly. So some patients will lay flat just for maybe 15, 20 minutes afterwards, not the entire day. But it's still a procedure, so there are still some precautions to take. We want you to avoid heavy lifting for at least the first few days, so we minimize the risk of other levels fracturing. But like I said, most people experience some form of pain relief. It may not reduce the pain in its entirety, but if it at least reduces the pain enough for you to be more mobile, more functional, get into therapy, then that means we're on the right track. But patient selection is key. And I see a lot of patients who come in with fractures, but not every patient gets that kyphoplasty procedure. So it depends. How acute is a fracture? Sometimes I see patients, the fracture is 6 months old. Maybe it's not worthwhile doing it, even if it's 3 months old. How compressed is the bone itself? 25%, 50%? If it's 90% compressed, and maybe the risks outweigh the benefits in that case. Are there other signs or symptoms, such as symptoms into the legs or other different types of pain that we aren't taking into consideration? And are there health concerns? Are you on blood thinners? Can you come off of them? Other conditions where it's just not safe to do the procedure? And to me, one of the most important questions is there pain? So as I mentioned a few slides ago, if we treat this conservatively with bracing, time, pain medications, and you're doing better, then may not be reason to do this procedure. But despite conservative measures, if pain still exists, then we could have that discussion again about whether or not you should proceed with the procedure. So in conclusion, compression fractures or fractures of the spine can cause acute onset back pain. We could do physical therapy, bracing, medications, and if that fails, we could do a minimally invasive outpatient procedure called a kyphoplasty to help reduce the pain and provide some stability and balance to the spine. Again, not all compression fractures need to be treated with the procedure. Conservative sometimes is best. And I think no matter what procedure you get done, whether it's kyphoplasty, surgery, injections, patient selection is key. That's why it's important to come in, have a chat with myself or one of my colleagues and decide what the best plan or approach is. Thank you. I think that will go for some questions.
Thank you so much, Dr. Sundar. Yes, it is time for questions. We will be answering questions submitted earlier and questions submitted live. So if you are watching this live on Facebook, please feel free to leave your questions in the comments section. We will answer as many questions as we have time for, but not all questions will be answered. Our first question is, do compression fractures ever heal on their own? And if so, how long does it take?
Yes, so compression fractures definitely do heal on their own. That's why we get into the conservative approach versus the slightly more minimally invasive approach. The purpose of the conservative approach is everything is stable, you're not in pain, so just let it heal on its own. Typically, within the 2.5 to 3 month mark, things start to heal. Once in a while, I have seen patients in the 3 to 4 month mark where we get updated imaging. They're still in pain. They're still, shows swelling in the fracture. So we'll go ahead and do it. But I would say to be a safe answer is roughly 3 months for it to heal.
Thank you. What nerves are impacted with a compression fracture?
So that's a good question. So if the compression fracture is isolated to the bone itself, the bone does have nerves in it along the top and the bottom, which are called end plates. So typically those are the nerves within the bone itself involved. Now, sometimes if the fracture is complex enough, it can involve a disc herniation or a big impingement of the other big spinal nerves. And that's when you'll see maybe pain traveling down into the gluteal region or down the leg. And if that's the case, they'll have to come up with the right treatment plan. Do you treat the leg pain or the back pain? because a fracture in and of itself shouldn't necessarily cause that shooting electric like leg pain.
Thank you. How do you treat the underlying osteoporosis with a vertebral compression fracture?
So it is important to treat it. I personally don't treat it because it depends on the degree of the bone density loss and, other medical conditions. So I will always defer to the primary care physician or the rheumatologist. And if the patient doesn't have a rheumatologist, we could provide a referral, because the simple answer is vitamin D supplements, but it goes beyond that. For some patients, they need injectable type of medication or other prescription medications to help rebuild the matrix of the bone. And, is it a hormone issue? What if the patient needs different hormonal therapies? So it's not a simple answer to say how it's treated, but the best answer I could give is we will refer you to the people who know how to treat this from a medication perspective.
Thank you. Do compression fractures show up as osteoporosis on x-rays, or can you tell the difference?
Yeah, so on x-ray, they could definitely tell a bone sometimes between weaker bone and, let's say, a 15-year-old very dense bone. It may almost look translucent and weaker and almost glass-like on an x-ray. It's not always crystal clear, but sometimes you can see changes on just the x-ray alone. But despite that, I see, some form of bone density scan is still warranted, so we get a true definitive diagnosis.
Thank you. Is it possible for bone spurs to form after a compression fracture?
It's possible. Bone spurs inherently are formations so for those who don't know, bone spurs is a little spike or outgrowth of bone that can occur. I would say if it didn't exist before, it may or may not exist now, but it definitely can occur as the bone remodels and heals. But we wouldn't go in and treat it just for the bone spur, because oftentimes if you don't have a fracture and just have arthritis of different joints of the spine, you may have bone spurs anyway.
Thank you. If someone has had fusion surgery due to past compression fractures, do they need to be concerned about future fractures?
So I guess if I understand, the fracture was severe enough that required fusion of the spine. Maybe there was some sort of instability. Theoretically, if that particular segment was fused, maybe that segment itself should have a significant decrease of fracture. But if you're already at risk of fracturing, unfortunately, the risk of other levels fracturing does exist. It doesn't mean it'll occur, but the risk of fracture does exist to different levels, maybe not the same level where that patient is fused.
Thank you. We had a couple of people ask if sores can form on the skin of the back after compression fractures, and if they can, should they see a dermatologist?
In the ones I have treated conservatively, I can't recall seeing any sort of skin changes from the fracture itself, especially because the area where the fracture is the deeper portion. It's not necessarily on the skin surface. That's a good question. I don't know. I'm open to learning something new.
Thank you. Can compression fractures cause shortness of breath?
You could argue the pain itself, if the pain is that significant, it can cause, shortness of breath. But if for whatever reason, if you have a higher up fracture and it's significant and it's affecting other parts of the spine, it can. But all things being common, if it's a low thoracic or lumbar low back type fracture, the fracture in and of itself, in my opinion, shouldn't cause shortness of breath, unless there's other sequelae because of the fracture causing that shortness of breath.
Thank you so much, Dr. Sundar. That is all the questions we're doing for today. Would you like to close?
Sure. No, thank you for everyone for logging on and submitting your questions. Like I said, even if you have back pain that's sudden in onset, please make an appointment with myself, one of my partners, or one of our spine colleagues. So, we could get the workup done, get you treated, either it's with just medication and bracing or with the procedure, and, refer you to the appropriate people if need be. And hopefully you don't get a fracture, but if you do, we're more than happy to treat you. Thank you.